Good morning or good evening wherever you may be. This is a joint presentation between myself, Eileen, and my colleague Lisa. And continuing on with the theme that has been presented thus far, we'd like to tell you our story. Our final year students were sent home after week 5, and as you can see, their 2 planned blocks were very much shortened with a deficit of some 9 weeks to make up. There was a number of outstanding competencies, the categories being planning, CT, treatment, patient care, imaging and ancillary equipment. And what we've detailed there in red are the strategies that we employed to make up for some of these missing competencies and experiences. We also made sure that our students documented everything and created a clinical experience log to meet the requirements of our Medical Radiation Practice Board. The first thing we got our students to do was to complete a certificate in COVID-19 infection control. We wanted our students to be prepared if they were allowed back into clinical placement. I'll now give some examples of some other things that we did. When we knew that our students were going to be sent home, we quickly asked a few of them that were still out in placement to construct some videos on CT with the mannequin. These were used for other cohorts as well. Our Year 3 students at the time had a superficial X-ray focus. They'd done a clinical markup, a calculation, and they'd created a treatment chart. And so our 4th year students were given the task of quality assurance. So they got 2 treatment charts each, and they had to give some feedback on that as well. So you can see here's an example, and we've got the Year 3 and the Year 4 names on the top there. There was some great feedback given from our Year 4 students, so it was a good clinical task and feedback from their peers. Next, we had a real patient come and talk to our 4th year students via Zoom. This patient was a head and neck cancer patient and talked extensively on her side effects. What you can see there is her holding up the glass of water, and she was explaining that it actually took her a whole hour to swallow that glass of water. Our students then filled out their normal participation record that they would have done clinically, detailing the information given to them by the real patient. Wrapping up block 1, our students got together and I asked them to rate the activities that they'd completed in terms of authenticity and future application. We used the whiteboard function in Zoom, and here you can see the outcomes of putting them into breakout rooms, and you can see some commonality in the things that were most valued of the activities that they had completed.
So for the second block, we knew that the students were only going to be on 3 weeks of clinical placement. And we planned uni-based activities to make up for the 5 weeks of clinical experience that was missed. This table shows the planned activities to cover those 5 categories of different competencies. And students are also required to complete 5 treatment setups, which need to be done during those 3 weeks of placement, and 5 computer plans or dosimetry, which is completed at university. Highlighted in red are the activities that we'll be talking about today. To complete the 5 planning competencies required for the second block, students are required to come into campus to access Pinnacle planning software, as unfortunately they were not able to have remote access to the software. And the extra complication was that only 8 students were allowed to be in the room at any one time to comply with social distancing requirements. The course coordinator was required at that point to be working from home, and so the Slack messaging platform was used for the students to easily post questions, and they can include images that were available to the whole group. It was easy for a quick response to come that way rather than keeping track of many different emails. Students were connected with clinicians in departments locally and also interstate via Zoom to complete the competency assessment for the different plans. So students arranged these meetings via email, and the clinicians had remote access to the student screens to assess their Pinnacle plans. The CT SIM requirements were completed using the Siemens CT SIM software. During the first clinical block, the students had access to this software in a group Zoom session Then in the second block, we were able to build on this experience, allocating the students groups to work on different sites where they could scan the site, obtaining a scout image and subsequent CT images, writing up an imaging protocol for the site that they have completed, and reviewing the final images. Students used the VERT software for cone beam CT matching, where they completed a series of cone beam CT matches for 3 different sites and had an associated worksheet with that activity. In conclusion, these 2 blocks showed us that the students adapted really well to these different working conditions. They were very understanding to the challenges faced by both us at uni and the students themselves, and they proved to be very resilient. We did find some benefits from these changed working conditions that included the uni-based planning with the online clinician assessments was something that was well received by the students and the clinicians, and we are considering implementing that going forwards. The group Zoom meetings and use of Slack for group communication worked well with the group of students, and also may be implemented in the future when students resume normal clinical placements and can be rostered at different departments all over the country. This is a good way of us being able to keep in touch and bring them together. And also the increased use of VERT image matching is something that we can use further, where the students are able to gain good practice with VERT.
So despite the challenging situation that we've all faced over the last little while and the multiple Zooms, we're still laughing and would happily take any questions. Thank you very much.